and thank you everyone for joining us today. Jackson Paul Pharmaceuticals Limited Pharma Division would like to extend warm welcome to the experts and attendees for joining this web series, Experts Speaks, organized by Dr. Archana Verma with Aligarh Ops and Gynae Society and academic partner Jackson Paul Pharma Limited, makers of Endoreg Divages range and our newly launched Lycored M tablet. We are proud to announce the launch of quality product Lycored M tablet for male infertility, a rational combination of L-N-acetyl cysteine, L-R-carnitine, tocute, lycopene, zinc, and selenium. With added advantage to win the race, L-carnitine is sourced from Switzerland and lycopene is sourced from Israel. We would also like to present our range of natural micronized progesterones as Divagest. For today's web series, Expert Speaks, I welcome Dr. Namrata Bhardwaj, Secretary, Aligarh Ops and Gynae Society, and Dr. Nilanjali Singh, Assistant Professor, Department of Ops and Gynae, AIMS, New Delhi today. Ma'am, I welcome Dr. Namrata Bhardwaj. Please proceed.
Thank you, Dr. Amit Saxena. Thank you very much. I welcome wholeheartedly all the experts, all the esteemed faculties, and all my seniors present here. And at the very outset, I would like to invite our dear Dr. Archana Verma, ma'am, whose vision has enabled us all to get together today. And ma'am, may I please invite you to welcome our chief guest and guest of honor. Thank you.
शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमा वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा.
Thank you. Now, I really welcome you all to this my special program which I planned along with Sneha Buhar and Namrata. This is one program which is quite close to my heart, and I always think that it is not in the stars to hold our destiny, it is in ourselves also. So it was said by the William Shakespeare, and I really like this. And so this program was made with the common problems where very experienced and very expert speaks about the clinical solutions about them. Because nowadays it is the hypertensive disorders which are so common in pregnancy and otherwise also. So Dr. Sneha Buhar will be taking that, and very common is again the need of the infertile patients counseling and management. For that we have today a very real expert, Dr. Pratik Tambe, and I welcome our chief guest, Dr. Rajendrasing Pardeshi. Dr. Pardeshi is one person, I must say, he is a very much for everybody. And in the FOGSI, I first met him in Mumbai, and then since then I know that he is a one person who was a real being human. There are so many persons you met, so many seniors, so many mentors. Everybody has some unique personality. Dr. Rajendrasing Pardeshi is one person. First day only I could see that he will protect us and he will help us like a big brother. And since then I always call him, and I really appreciate him, and really so much of respect for him. He's a highly academician, and his motto of bringing down maternal mortality is one passion which he's doing and he will be doing. And he's a best paper awardee, 7 continuous. That this is not something very easy job, and so how dedicated he is. So now I welcome Dr. Rajendrasing Pardeshi. to bless us. And then I will welcome our guest of honors who are very, very renowned, Dr. Kalyan and Dr. Ajay Mane, sir. Dr. Rajendrasing Pardeshi, sir, please welcome.
Thank you, Dr. Archana, for kind introduction. Good afternoon, everybody. Respected Dr. Sampathkumari, Dr. Ajay Mane, Dr. Kalyan Barmade, and Chief Convener, Dr. Archana Verma. Dr. Kalpana Balamurugam, Dr. Sneha Buyar, Dr. Pratik Tambe, and panelists, Dr. Seema Hakim, Dr. Namrata Bhardwaj, Dr. Nilanchali Singh, Dr. Aparna Rao, Dr. Sambul Takkir, Dr. Anusra Pandey. First, I will congratulate specially Dr. Archana Verma for organizing such a nice academic and practical webinar. She is not only an academician, but she is a great human being. And she is an excellent organizer. We still remember her tenure and public awareness committee, so many programs, and not in the region, but all over India. I again congratulate Dr. Namrata and the team Aligarh Bhardwaj Society for organizing this webinar, and also with Dr. Sneha Buyar. We all know that hypertensive disorders are still a major cause of maternal mortality. Dr. Sneha Buyar, a right person, will be moderating this panel on PIH. We still remember Dr. Archana Verma's memorable tenure, in which she had also taken this initiative at that time, her vice presidential tenure. With the eminent faculties like Dr. Pratik Tambe, Dr. Sneha Buyar, and all chairperson panelists, I think this will be a great webinar. I wish every success to Dr. Archana Verma for her future endeavor in FOGSI. I wish every success to Dr. Sneha Buyar for her future endeavor in FOGSI as Vice President FOGSI. Thank you so much for inviting me. Thank you.
Thank you so much, sir. Thank you, sir. Thank you for giving us time and recognizing our efforts. Thank you, sir. Your words means a lot, and your wishes means a lot to us. And so now next in the program is because we have very, very famous and a medical legally expert, dashing personality, I will rather say Amitabh Bachchan of FOGSI, Dr. Ajay Mane. He is a member of NIMC, National Inspection and Monitoring, PCPNDT Wing, Government of India. He is a medical legal consultant since 18 years. Aurangabad से सर बहुत बड़े हमारे Vice President now will be there, and he was a chairperson of Sexual Medicine Committee, chairperson officially AMOGS, and he's a brand leader in AMOGS. So I welcome Dr. Ajay Mane. उनके लिए तो I always used to say one word, कोई माने या ना माने, अजय माने के हैं सब दीवाने. Welcome, sir. Dr. Ajay Mane, please, sir.
Thank you, Archana madam. So I am having 3-4 my elder sisters in FOGSI. So Archana Verma will be the first elder sister, and now Miss Sneha Buyar is my elder sister. So this is my request, first of all, to kindly support her in her endeavor. So respected Archana madam, my mentor Dr. Rajendrasing Pardeshi sir from the same place, my younger brother Kalyan bhai, then Kalpana ji, Dr. Seema ji, she is not there I think, Dr. Namrata ji, Dr. Nilanchali ji, then all the panelists, Anushri, Dr. Sumbul, Namrata ji, and Aparna Rao from the Aurangabad Society. So today you have conducted. See, basically everybody works when he or she is having one post, but there is one specialty from Archana ma'am that she is working. She was Vice President 21-22, I think. Is it correct? No, Vice President FOGSI, but still she 21. Is working and she will go on working. So that is a typical academician behavior by Archana madam. So I congratulate her. And I congratulate the team of Archana ma'am and Sneha ma'am, Namrata ji, Kalpana ji, and my younger brother Kalyan, who is now having a very vast experience and academic participation in IAG as well as FOGSI, both. And he's doing very nice work in both and as well as practice also. He's having 100+ OPD daily. So the biggest achievement is that in spite of having all the activities, he's having his own setup and running very nicely. So because see, some of the other time I come across the patients from his place, because my place and his place is very nearby. The patients are satisfied. They say कि Kalyan sir is very nice. Kalyan sir is very nice. So बहुत कम लोगों के बारे में ऐसा patient बोलते हैं कल्याण भाई. So you are one of them. So it is very nice to hear from the patients. It is from horse's mouth. So today's two topics. One is by Pratik Tambe, and he'll be speaking on antioxidants in male infertility. Basically, nowadays we are going back to our Indian medicines. See, we have followed modern medicine for 250 years, and now we came to know that our ancient Ayurveda, yoga, and our nutrition is the major portion or major part in our health, and that's why these antioxidants works. So Pratik, who is an academician person again from Maharashtra, will be giving the talk, and my sister Dr. Sneha will be conducting the panel, which is very important in pregnancy-induced hypertension. Now they call it as a hypertensive disorders of pregnancy. Whatever the name may change, but the complications are there. We are reducing the maternal mortality. We have brought from 600 to 29. And as Rajendrasing predecessor wished all of us on day 1 of the year. So we'll be trying to bring this to the single digit and try to finish it. So I congratulate all the team, Archana ma'am and all the team, and I wish you all the best. I wish Sneha ma'am for her endeavor in the FOGSI, the Vice President. And thank you very much. Thank you for calling.
Thank you, Ajay. Thank you.
थैंक यू डॉक्टर अजय माने जी. आपके वर्ड्स बहुत सही हैं और हम we will be looking forward to work with you and to work under your guidance, and then I think thank you very much for giving so much of your precious time to us. Thank you. Our next guest of honor is biggest Dr. Kalyan Barmade. You know, when I joined, when I was about to go from my tenure was being finished, then Kalyan was contesting for public awareness committee, and somebody told me he's a big person, and so I felt very happy. At least my tenure finished, and now Dr. Kalyan is coming. So otherwise, Pura he would have shadowed everything in public awareness committee, and he really worked so hard. And somehow, I with folded hands, I want to say that he is a friend of friends. And he always doing so much for his friend and his community. He's not only a doctor, I think he's a leader of Latur. I must say something great connecting to politician level also. And now we can see that he's a voice for doctors also, and he always help IMA also. And this Latur and Maharashtra and AMOGS, once he invited me to a big program, and as a big there was a talk and guest of honor, oration rather, I must say, and I was unlucky enough not to go there and could not join because of some issues. And so I really appreciate Dr. Kalyan. He did one biggest program of FOGSI, which is very, very important, and still till date it is a program of Government of India, and very, very precious program of Save the Uterus campaign. And we are all very proud of him, and I congratulate Dr. Kalyan, and please, Dr. Kalyan, give your words of blessings and words of wisdom for all of us, and how we should work, and how to work in unity, and how can we be more be doing work to save the uterus.
Thank you so much, ma'am, for this kind introduction. I'm very small person. What you have said is just 1% right, because I am a worker. And one thing I remember in life is united we stand. That is what is required in today's world, because people are not as they were previously 20 years back in practice. They all change a lot. So we need to change accordingly. And my mentor, Dr. Pardeshi sir and Dr. Ajay Mane, who are taking so many medical legal issues across Maharashtra, have taught me ABCD of what to do in which cases. So I am really grateful to these two leaders. So I really thank Chief Convener, Dr. Archana Verma ji, the PAC Queen, I say her, because whatever PAC is in limelight is because of her. Chief guest, Dr. Pardeshi sir, he's my mentor. I like to say a few words which are away from the webinar point of view. Dr. Pardeshi sir and Dr. Ajay sir are the one who picked me up from a village and got to the FOGSI platform. So I just bow in front of these two guys who are really made me whatever I am today. And chief guest and Dr. Pardeshi sir, I am really grateful to you. The guest of honor, Dr. Ajay sir, as Archana ji has rightly said, he is Amitabh Bachchan of OBGYN, because वो जहाँ से शुरू हो जाते हैं वहाँ से line शुरू होता है. And because he is the one who really guides all youngsters that which is the right path for you, which is important, and that path should be always ethical. He always says me, wait karo, aapka bhi number aayega. Because that is the thing which is, I say, our Sai Baba says, Shraddha and Saburi. What I learned from Pardeshi sir and Ajay Mane is these two words. Shraddha is that you just follow somebody, and Saburi is patience, which is lacking in today's generation. And that is what we should do also in practice, so that we have less violence in our practice. I really congratulate one more person, Dr. Sneha Bhuya. She is my elder sister, who has done so much for AMOGS and for FOGSI and REST committee, that whatever we see today, she's taking so much of efforts in spite of her last year election results. I really admire such person who is there to work for the FOGSI and betterment of all FOGSians, and the common thread which is binding every one of us is a women, because we should be doing best for the women at the villages, at the cities, and whatever the women who are coming to us for the practice, and she's following all her norms. So I again say to her, you are going to win this time, because Shraddha and Saburi. She has a Shraddha on FOGSI, and Saburi is the important thing, patience. She's continuing all her hard work since last 2 years. So that is what is Saburi, and that is going to win her this election. I wish all the best for her. I really thank Dr. Namrata Bhardwaj, Dr. Milanchi Singh, and all team who has organized this webinar in such a grand way. So I congratulate everybody. And the two topics which we are going to discuss today is antioxidants in male infertility. As an IVF consultant, I feel always a male comes to you. One day his reports is normal, another day his reports are abnormal. And the antioxidants are needed. We are going back to the basics again. Previously, our diet was so good that we had a good sperm count, but now the diet is not good. There is a global warming, and there are chemicals in our food. There is adulteration of milk, adulteration of the food, and that is why the sperm count is decreasing. And Dr. Pratik Tambe, who is a very renowned infertility specialist, is going to throw light on this light subject that is called antioxidants in male infertility. The another thing is panel on PIH. Everybody knows PIH is the only disease which pathophysiology we don't know till today. So every time if there is a OBGYN conference, we have lot of crowd at PIH panels, PIH lectures, because this is an enigma for everybody. And today we are going to see what are the newer modalities for diagnosis, prediction of PIH. That is very important, role of color Doppler. All these things are going to be talked today. And apart from health syndrome, renal complication, coagulopathy, and all those diseases. So we have a person, able person, Dr. Sneha Bhuya, who is going to talk on this issue. So I really thank Dr. Archana ji for inviting me as guest of honor. And I thank all the team like Dr. Namrata, Dr. Singh for having such a wonderful webinar, which is going to enlighten academically everybody, and is going to be a great source of learning for everybody. Thank you so much for inviting me.
Thank you.
Thank you so much,
Thank you, Dr.
Kalyan, for
Kalyan.
your precious
Thank
words.
you.
Thank you so much.
Really, one line was the best, that medico-legal workup and medico-legal persons are going to be our great friends, because unity and is one thing, and doing work under protocol is really needed. Presently, Vice President Dr. Sampathkumari Madam, I think she's not joined, but welcome Dr. Sampathkumari Madam, and she is Vice President FOGSI at present, and Founder Secretary of this Tamil Nadu TNFOG, and National Correspondent Editor. She has worked so much for adolescent health, and she's a really a very famous person from the FOGSI, and I would like to listen to her. I think if she's not here, she will definitely join. She's really a committed person. So thank you. Now, Dr. Namrata, you start the academic session so that we
Yes, ma'am.
finish in time.
Thank you, ma'am. Thank you. Thank you to Pardeshi sir, Mane sir, Kalyan sir for your kind words. And we're really indebted to have you here in our program today. I would like to welcome Dr. Kalpana ma'am. I had the pleasure of visiting madam's health facility. It's such a huge and such a beautifully placed health facility, madam. When I went for the South Zone Vice President Conference, ma'am. We are happy to have you here as the chairperson of the first session. She's the National Coordinator Infertility Committee, as the course director for postdoctoral fellowship in endogynecology, chairperson Infertility Committee, Tamil Nadu. And I think if we keep on telling, madam, your achievements, we would run out of time. So I would like to invite you as the chairperson of the session by Dr. Pratik Tambe, sir. Dr. Seema Hakim, my president, is busy in a surgery, so she has not been able to join, unfortunately. So, ma'am, I think I'll invite Pratik Tambe, sir. Sir, welcome. Welcome virtually to Aligarh again, sir. We had the pleasure of meeting at Aligarh first. Namaskar. And welcome again, sir, to our webinar. Sir is the ART consultant and gynec endoscopic surgeon, and is a chairperson AMOGS Endocrinology Committee, governing council member ICOG, executive committee member ISAR, and oh my God, there's so many of his achievements which I really would not be able to enumerate today. Sir, we welcome you as a speaker in our webinar. Sir will be talking on antioxidants in male infertility. Over to you, sir. Thank you.
Thank you very much, Dr. Namrata Bhardwaj. Let me begin by thanking Dr. Archana Verma, who has organized innumerable events in the past several years. So I remember fondly my time at Aligarh. I was there just a few months back, and Dr. Seema Hakim, Dr. Namrata Bhardwaj were very fantastic hosts. The entire society had turned up. It was a full hall, and I was there to speak on PCOS. So I have fond memories of that occasion. Today I'm here to speak to you on
मेरा
micronutrients.
alma mater है वो अलीगढ़.
Same blood hai, same pani hai. So I'm here to speak to you regarding micronutrients in infertility. I've taken the liberty of expanding the topic a little bit. We won't really focus only on antioxidants. We'll try and talk about micronutrients as well. And there's a reason why I have chosen this topic. Believe it or not, this was the very first talk that I gave on a public platform almost 20 years back when I started public speaking. And of course, this is not the same presentation. It has been updated over a period of time. Purana jisa pita PPT nahi hai. So it has been updated with all the latest evidence. What I have learned from studying, and as you know, medicine is lifelong study and lifelong learning. The only true wisdom is that you know nothing. And by the time I finish this talk over the next 15 to 20 minutes, you will realize the truth of what I am saying. That we have forgotten some things, we have learned some things, we need to unlearn those, and maybe we need to refresh our memory, we need to look at things with a different perspective when we talk about micronutrients. So I've spoken regarding the role of micronutrients in several different key areas of human physiology. That includes male and female fertility, as mitochondrial energizers for ovarian rejuvenation, and of course in pregnancy as well. I'll quickly take you through some of the basics. First, we need to understand which micronutrients we're referring to. if we are going to talk about them. And this list is by no means exhaustive. All of these are known to us since maybe fifth or sixth standard when we were in school. We have heard of all these molecules, we are aware of them. What we don't realize is the profound impact they have at a microcellular level in each and every single cell of the human body. It's only 500 milligrams. If you put all these micronutrients together, which is less than 1,000% in the human body, you look at 70 kilos average weight, but you'll realize that all of these micromolecules are very important in day-to-day life. Iron is well known to all of us. I'm going to skip past the basic slides so that we get on with the topic. We know that zinc is important because it's important from the RNA, DNA, and protein synthesis point of view. It's a cofactor for over 200 enzymatic reactions in the human body, including metalloproteinases, transferases, phosphoreductases, oxydoreductases, etc. Your entire Krebs cycle basically depends on zinc, and without Krebs cycle, human body doesn't function. It's also been implicated, that's the last line here at the bottom, in the functioning of insulin. And one of the ways in which you can try and achieve better ovulation in PCOS patients is to simply supplement zinc in the right amount. It seems to work. There are studies to say that it does work. There are also other molecules like manganese, copper, and selenium. We know that selenium is very important in the functioning of thyroid, specifically the 5-iodotyrosinase enzymes and the glutathione peroxidase enzymes. Copper is important from the catalase, cytochrome oxidase, and superoxide dismutase point of view. And we know that a lot of complications which occur in pregnancy, notably PIH, which Dr. Sneha Goyal is going to later speak on, can be mitigated or to some extent curbed if we were to supplement these micronutrients in the right concentrations, in the right ratios, pre-pregnancy and of course during pregnancy. In fact, during the COVID-19 pandemic, it was found that if you don't have the right proportions of copper and zinc in the body, that makes you immunocompromised. And we all know that 2-3 years ago, when we were confined to our homes, we were popping a lot of zinc pills, and there were actually some companies who made crores and crores because they were marketing these pills. Coming to the impact on male fertility, I have a beautiful article here. This is published in 2019, and this is in the Reviews of Environmental Health, which talks about the role of trace elements and micronutrients in human reproductive health and sperm fertilization. So calcium is required for sperm motility, capacitation, acrosome reaction, and chemotaxis. Sodium and potassium, if you remember your first MBBS, probably the very first lecture that you had in your first MBBS physiology is the sodium potassium ATPase pump. This is extremely important in the sperm cell as well, and it's also implicated in sperm motility and capacitation. Magnesium is required for normal ejaculation, spermatogenesis, and motility. Zinc we've already talked about because it's a very important way in which we can mitigate oxidative stress and reactive oxygen species. We'll come to that in just a couple of minutes. Also, we've tackled about manganese and copper. All of these micronutrients are required for normal sperm motility, and they're also required for the fertilization process. We briefly talked about selenium a couple of minutes ago, and there is a beautiful article here which I have. This is published quite some time ago. And the reason I'm putting this up because there's actually a journal for trace elements in medicine and biology. If I had not been studying this subject, I would not even have known that such a journal exists. See, such is the beauty of science. So this talks about the role of selenium in human conception and pregnancy. Selenium is a natural antioxidant. It is known to be deficient in some populations, especially those which are staying far away from the seaside, and the populations which are coastal areas, they have less deficiency of selenium. It's implicated in sperm count and also in a lot of fetal as well as neonatal issues. In the female, it is supposed to be responsible for the normal growth, maturation, replication of oocytes. Declining sperm counts is nothing new. It has been breaking news for the past couple of decades. I remember reading in the 1990s in my medicine textbooks that the normal sperm count was 120 million. Today, if I find somebody who has a sperm count of 120 million, probably they deserve a Guinness Book of World Record. because very rarely do I see sperm counts more than 10 million in my clinical practice. And it has been postulated that over the period of the next 50 to 60 years, human beings could be extinct simply because the sperm counts will reach a point where, as a species, we humans are no longer viable. This is because there is an astronomical increase in what we call reactive oxygen species. There is something called as oxidative stress, which happens in every cell of the body, but specifically the human sperm cells are very much sensitive to these. And you will find that the protein damage, lipid peroxidation, biomembrane damage, and DNA damage, which happens to the sperm cells, are the ones which result, they manifest as declining sperm count, less motility, and finally less fertilization and infertility. So this is what we talked about. There's loss of DNA integrity, cell death, apoptosis, reduced fertility, and the sperm cells are more susceptible to this because there are large quantities of polyunsaturated fatty acids in the plasma membrane, which makes them especially susceptible to ROS. There are low concentrations of the scavenging enzymes, and those scavenging enzymes are actually concentrated in the head. They cannot protect the midpiece and the tail, and that is what results in poor sperm counts and poor fertilization ultimately. Variety of reasons why ROS levels increase. All this is known to us. It's not exactly rocket science. But finally, what we need to understand is that lifestyle modification with all of these being countered is probably one of the best ways in which we can help our patients. Also, we need to be aware that whatever micronutrients or antioxidants we prescribe, unless all of these lifestyle factors are first addressed, none of your expensive antioxidants is going to function. There's this beautiful paper, it's a meta-analysis and a systematic review published in RBM Online in 2019. And this looks at all the studies which have been published so far and specifically whether these are going to be of benefit in finally improving fertility. Now, most of the studies which you will read, they will say, yes, there's an improvement in the sperm count, there's an improvement in sperm motility. Sometimes they will state that there's an improvement in the semen morphology parameters. What they don't tell you is finally whether that results in clinical pregnancies and whether finally that couple has a live birth again. There are very few studies which follow up the patient to look at the improvements in the CPR and the LBR. So this particular meta-analysis had 18 RCTs and there were 12 studies which were meta-analyzed, and they found significant improvements in semen parameters when selenium was supplemented, when L-carnitine was given, and when coenzyme Q10 was given. But what about the clinical pregnancy rate and the live birth rate? You'll find that most of these studies, there is no data or the number of participants is too less. And finally, whether these studies are actually representative of the general population, your guess is as good as mine. But what they found is that supplementation with these particular molecules is beneficial in the treatment of male fertility as far as improvement in semen parameters is concerned. There are specific molecules which I'll briefly talk about quickly. One of these, which came out almost 15 years back, is astaxanthin. The reason why I'm mentioning this is because this is actually a nutraceutical. It's not a medical compound which you need a prescription. You can buy it from Amazon. It's available over the counter. And in Western countries, this is one of those molecules which is consumed by athletes, including marathon runners, triathlon athletes, cyclists, swimmers, so on and so forth. The reason for them consuming this is because it has 500 times greater potency than vitamin C and vitamin E, which is the most common poor man's antioxidant which is prescribed. When they can't afford anything else, you prescribe them vitamin C and E and zinc. It also crosses the blood-brain and blood testis barriers, and it's supposed to be instrumental in improving the health of the person when they are recovering from disease or an injury, for example. 16 milligrams per day is the recommended dose, and there's this paper published long back which showed that clinical pregnancy rates significantly improved. As I said, there are very few papers which talk about CPR and LBR. Most of the time, they'll only talk about the semen parameters. What about female infertility? Quickly, we'll just go through this because the talk is mainly about male fertility. I don't want to talk too much about female fertility. But yes, they are known to be beneficial. We know all these molecules. We've read about them since our undergraduate and postgraduate days. We also know that there are some things which come up in our social media. In fact, if you go to Pinterest, you go to Facebook, you go to Instagram, there are a lot of influencers. There are a lot of people who are, in inverted commas, nutritionists. There are registered dietitians who will promote something called as a fertility diet. So this is a review which was done, which looked at so-called fertility diets. What did they find? They found that the dietary trans fats are the ones which have the greatest harm as far as oocyte and sperm quality is concerned. And healthy diets have led to improvements in live birth rates. Unhealthy diets have consistently had the opposite relation. But unfortunately, there is no universal agreement as to what is a healthy diet, and there are no head-to-head comparisons, there are no randomized trials. So we are at the mercy of the social media influencers saying that XYZ is the best diet which improves fertility. So the jury is still out on that. Coenzyme Q10 has been touted to be the best thing since sliced bread. Every single pharma representative will come to you almost on a weekly basis and say that my preparation is the best, this is the reduced form, this is the correct dosage, etc. etc. So is there practical evidence for this coenzyme Q10? And if you go back to literature and read, this is from the EV Valencia group. This is what they published a couple of years back. They found that reactive oxygen species lead to a lot of oocyte dysfunction because there is mitochondrial damage. This mitochondrial damage and reduced mitochondrial function leads to poor quality oocytes, just as it leads to poor quality sperm. And this coenzyme Q10 is supposed to be a mitochondrial energizer. It is the one which is directly involved in the Krebs cycle, as we said a few minutes ago. And this is what gives you better quality oocytes, better fertilization potential, and good top class embryos. So where can you use this coenzyme Q10? Obviously, you can use it in the form of capsules, which are consumed orally. You need to give them for at least 2 to 3 months to see a benefit because, as we know, the spermatogenesis cycle is about 90 to 120 days, and the oocyte cycle is again 60 to 90 days. You can, of course, use it orally, and you can also inject it directly into your petri dish, and this is how you use it in vitro as well. Beyond the scope of today's talk, we talked about IVF and addition of coenzyme Q10 to petri dishes because that will become a very specific and a very, how can I put it, research case. But what we do know is that oral supplementation increases clinical pregnancy rates and there is significant improvement when compared to placebo. Your clinical pregnancy rates seem to double, 28% versus 14%. But again, these are small numbers, only 5 trials. When you have a patient who is at the end of their tether and they need something which is going to work, this is what you can offer them. Counsel them that you may not see benefit, that these are expensive, this is still research based, and you may or may not derive benefit from. But today, when you get couples who have been running around from pillar to post for years and decades together, they will grasp at any straw that is offered to them. Coenzyme Q10 is also supposed to significantly improve oocyte quality. You have higher top quality embryos and lower oocyte aneuploidy rate. What this means is that you're going to have lesser chances of that couple miscarrying. Getting pregnancy alone is not enough. We need to ensure that that pregnancy reaches term and they have a live take-home baby. The one way in which you can try and reduce that is by reducing the first trimester miscarriage rate, reduce the aneuploidy rate. Finally, what are the recommendations for clinical practice? We have 2 Cochrane meta-analyses. The first is from 2022 on male subfertility. That's the reference at the bottom in case you want to look it up. 90 trials, more than 10,000 men, increased live birth rate, increased clinical pregnancy rate, but no difference in miscarriage rate. This is the short answer of whether antioxidants work in clinical practice. whether they only improve your sperm motility, your sperm count, and sperm morphology, whether they reduce your DNA fragmentation index, or they also result in better take-home fluids. Short answer is yes. There's a Cochrane which says so. And in case you are a student and you're listening to this, this is the reference that you need to quote. It's very new, very recent, and not many people may be aware of it because it came out during the pandemic and it flew under the radar. As far as female fertility is concerned, we have a slightly older Cochrane from 2020. Again, 63 trials, nearly 8,000 women, better clinical pregnancy rate, and better life birth rate. So yes, antioxidants are a ray of hope. They do offer better results in patient. But remember what I said, you must address the lifestyle factors first. You need to ensure that the other micronutrients are supplemented before you go ahead and supplement with micronutrients. None of these Cochrane meta-analyses will tell you specifically which agent works and which agent does not work. So therefore, you need to resort to trial and error, and you need to prescribe the combination which you think will work best in the couple sitting across the table from you. So at the end of the day, ladies and gentlemen, a few key practice points. Micronutrients are an essential component of the human body. They are present in every single cell in the human body. They are of extreme importance at all stages of life: follicular phase, luteal phase, ovulation, call it what you will, implicated in both male as well as female infertility. We know that supplementation improves both the sperm quality as well as the oocyte quality, results in better clinical pregnancy rates, live birth rates, and reduces miscarriage rates. Though that last point is something which the jury is still out, but we hope that it also decreases the miscarriage rates. There are no specific recommendations regarding an agent of choice. And I always love this quotation that the best things are the simplest. And that's what Lev Tolstoy said. There is no greatness where there is not simplicity, goodness, and truth. This is one of the ways in which we can help our patients, and they have been proven to work. It's not just something which you are doing to improve somebody's bottom line, to favor some particular pharma company, as we have been accused of time and time again. They definitely do yield results. Thank you very much for a patient hearing. Thank you, Dr. Archana Verma, for inviting me. Open to any questions.
Let Dr. Kalpana say something, then I will say one word.
First of all, thank you, Archana ma'am, for including me in this webinar. Unique webinar. The name itself says that Dr. Archana Verma's initiative. It is very unique, and I just really love that name. And it is
Next time change kar dungi naam.
It's my privilege to be here when Rajendrasing Pardeshi sir, Sampathkumari ma'am couldn't join because of an emergency. So after almost 6 months, I'm getting blessings from Rajendrasing Pardeshi sir, Ajay sir, and Kalyan sir. Ma'am, for your for this great opportunity, and Namrata, Seema, ma'am, all are not new to us because we have been working for a long time, and we had wonderful talk from Pratik sir. Always his talk is very interesting and informative. Thank you so much for the information you have given about antioxidants. With the literature evidence also, we have shown Cochrane Review 2022 latest evidence you have shown, even though it is very debatable, and Yashreed doesn't recommend CoQ for antioxidants for male infertility. Even then, many a times we see patients coming to us with 2 to 3 antioxidants taking for years together. Yeah, honestly, we have been practicing giving antioxidants to males, even though the evidence is not sufficient. We don't have robust evidence. Then also we have been giving because it doesn't have major harmful effects. Thank you so much, sir. And It's my privilege to be with Sneha Bhuya ma'am again, because we have been working for a long time. She has been working very hard, and hopefully she'll reach her goal in this year. Thank you so much for the opportunity.
So, Dr. Pratik Tambe very rightly said. I never tell my patient that she is a case of infertility. I always say that we are working for fertility. So this thing is the very first thing which gives positivity. And nowadays there is a lot of pollution, and the sperm quality and egg quality somehow either maybe lifestyle. A lot of changes in because of the lifestyle, and antioxidants definitely, I think, definitely help. So this talk is this supplementing, I think, is quite important, and periconceptional also we must consider. And this number of ovarian follicles and number of higher fertilization rates and higher clinical pregnancy rates also, I think, going to help us a lot. And not about pharma, but it is all about the antioxidants as such, because multivitamins, we never we used to think or read that they are so much important, but nowadays so many things and so many updates are coming, and this is one of the very important talk Dr. Pratik Tambe has given, and his talk is very, very special, and always even the slides and the way he gives the take home messages and his own work and his own experience, that is very, very important. He's like I always copy and paste and talk. But Dr. Pratik is one person who really works hard. I don't know how come in such a young age he has done wonderful work. I always congratulate Dr. Pratik and keep on doing this.
You're so right, ma'am. The more we evolve, the more back to basics and roots we are going. And we really need to rethink. Pratik sir, you wanted to say something? Sorry. Pratik sir, you want
I
to say
just wanted to express my gratitude to Dr. Archana Verma. We will see her very soon at ISOG in Hyderabad. Hopefully, I will meet a lot of you as well over there. Thank you again for this opportunity.
Thank you, Pratik sir. Thank you, Kalpana ma'am, for joining us today. And
with your permission, can I just have a slide show about our new product? So we proudly announced the launch of our Lycored M tablets, which are for the male infertility. It is a quality product which has a combination of N-acetylcysteine, L-carnitine, CoQ10, lycopene, zinc, and selenium. And this L-carnitine is sourced from Switzerland and lycopene is sourced from Israel. So to win the race, we have this added advantage of sourcing it from abroad.
At the very outset, I would like to invite the moderator of our next session on panel on PIH, Sneha Bhuar ma'am. Ma'am says a short CV, but her CV can never be short. Ma'am, let me tell you, you are and you will always be our VP. So no problem. I had the pleasure of meeting you. I have the pleasure of talking to you, and every time I meet you and I talk to you, I get more and more impressed. So all the very best, ma'am. The title is just a number, ma'am. And madam has been the FOGSI breast committee chairperson, and what a wonderful job she did with that. She's a SAFOG working group member, founder, president with her ISOPARB. And now she's the International MS Signature Award for phenomenal leadership. And we hope to gain a lot by your panel, ma'am. I just hope we live up to your expectations, because I'm a little scared of answering your questions, ma'am. I would like to invite Dr. Archana Raul, ma'am, who's the president of Aurangabad Obs and Gynae Society, Dr. Anushri Pandey, the past secretary Saharanpur Obs and Gynae Society, Dr. Sumbul Tokir, treasurer Aligarh Obs and Gynae Society, and myself, Namrata, secretary Obs and Gynae Society, Aligarh, for our panel. Ma'am, Dr. Sneha, ma'am, over to you, ma'am.
Sneha is one of the person who really motivated me. I am here only because of Sneha, because Sneha really hold my hand, Dr. Archana, don't worry, I'll help you in FOGSI. And she really did wonderful job. There are so many persons who just run and run and run. And I always say, believe your friends. They are there to help you. Because unless and until you trust them, nothing is going to happen. You have to trust them from your heart, and the friends always help. And she is a really wonderful person, most wonderful person. Even matlab, like everybody says ki, this thing matters or that destiny, as I first said, but brilliancy and commitment and very, very elegant person, and no time wastage, no nothing. If you want to know how a ideal person can be, the answer is Sneha. So welcome, Sneha.
Thank you. Thank you, my dear. Thank you so much for all your words of appreciation. And of course, I remain uninterrupted by all your words. I just take this opportunity to thank all of you, the platform, and of course, my dear friend, Dr. Archana Verma. I once again extend my gratitude towards my mentor, Dr. Rajendrasing Pardeshi, and my dear friends and my brothers, I would say Dr. Ajay and Dr. Kalyan Barmade. Hearty congratulations, Dr. Pratik Tambe. The talk was excellent, very informative as always. And with this, may I just go to the subject directly. So we are here to discuss the management of hypertensive disorders of pregnancy, because we have delivered n number of talks as far as the theoretical aspect of hypertensive disorders of pregnancy, as we have already discussed that it has got so many names, and so we don't talk about PIH, HDP, gestosis, but we just talk about the disease. And in spite of having so many screening tools, right from the maternal characteristics, as we have, the HDP gestosis score, which we should use in day-to-day practice, which is available on the Android app. In spite of having the biochemical tests like PLGF and SFLT and so many other markers, even the genetic markers, we are still not able to predict the hypertensive disorders to the max, and we're not able to, prevent it at all. But definitely we can recognize it early, and we can try to control or reduce the complications. So, as we always discuss, that hypertension, hemorrhage, and sepsis, these are the three major reasons of maternal mortality. So, as expressed by Professor Mohammed Fatala, I would say that women are dying not because of the disease we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. And similarly, it has been expressed by the Ian Donald. So without going much into the theoretical details, I would just say one point about this slide, that the pathogenesis, the basic pathogenesis is failure of the trophoblastic invasion of the spiral arteriole. That is the first and the second trophoblastic wave of invasion, which makes the changes into the vessels, changes it from the muscular vessel, which responds to the what we call it as angiogenic agents, to a non-responsive permanently dilated channel, which we call it as sinuses. This should be the normal physiological change, and failure of this physiological change results into this pathogenesis of preeclampsia, this eclampsia, as pre-eclampsia, as we call it as, or hypertensive disorders of pregnancy. So without much ado, we would like to go for the case discussion. I hope Dr. Archana, Aparna Raul has joined by now. Hello, Dr. Aparna, do we have you? Okay, so I think somebody else can take up this case. We have this 22-year-old primary.
Anushri is also there. I think Aparna was saying she's joining. Anushri has joined.
I just talked to her, but she said she will join immediately. So we just start with the discussion. We have this young primary gravida belonging to a low socioeconomic status, and she has no known medical illness whatsoever. There's no significant family history. She's booked with, registered, regularly coming for treatment, and everything was fine till 32 weeks of gestation. At 32-week gestation, suddenly her blood pressure is recorded as 140/90 in the OPD. How should we manage this patient? I think Dr. Namrata, we can start from you. Okay. Should we label her as hypertensive right at this point, or should we need to confirm, do we need to confirm that she really has hypertension? That is the first question to you.
Ma'am, the first thing that we need to do is we need to have her blood pressure recording for at least 3 days in the vicinity of 140/90 to number one. Number two, we need to get a urine albumin done, which is one of the most basic investigations. This will, since she's not been hypertensive in her earlier part of pregnancy, so we can easily rule out any kind of chronic hypertension. But to label her as a case of pre-eclampsia query, we need to have at least three repeated readings of high blood pressure and urine albuminuria at the very
So
least.
when do you want to repeat her? After how much time you want to repeat her blood pressure?
Ma'am, at least I think 2 readings 6 hours apart.
Yeah. So 4 hours, at least 4 to 6 hours, that should be okay. But do you feel that, some patients, they're very anxious, they're coming to hospital, they get their high blood pressures high, what we label it as white collar hypertension. So do we have certain ideal conditions, how the blood pressure should be, taken or recorded?
Ma'am, what we should actually do is get her away from the OPD settings at some place where she can sit and talk to her attendants and not see the doctor's face for some time, I think. So I think another 4 hours, and then ask her to relax, have a cup of tea or whatever. And then I think that is how we should be taking her blood pressure rather than repeating it over and over again in the OPD settings.
Okay, so after now with all the ideal situations that she's physically and mentally relaxed, she's in a comfortable place, she's wearing comfortable clothing, her bladder is empty and she doesn't have any stress, she has not consumed any drugs prior, not even the eye drops. So with everything, Prof, ideally now when you are measuring her blood pressure with the sitting position, right upper arm, now again after 4 hours it is 140/90. Now do you label her as hypertensive?
Yes, ma'am. If her urine albumin is...
And yes, then whether it is a severe or a mild hypertension, how do you decide that?
Ma'am, this will come in the vicinity of a mild hypertension because as the BP rises, in fact, I was just reading, you may correct me, ma'am, that now they have a diastolic of more than 85. They are taking as the cutoff for the PIH.
Yeah. So in fact, it is it is not the blood pressure which decides the severity of the disease. So I would go to Dr. Sambul. Do we have, is it the recording of the blood pressure which is labeled as hypertension, severe or non-severe, or are there certain characteristics to define it, the severity of the disease?
Thank you, Dr. Sneha. Blood pressure is not always an indicator of severity. There are other features we should also take into the consideration like headache, visual disturbances, convulsion, upper abdominal pain, breathlessness or pulmonary edema, proteinuria, especially if it is persistent 2+ or more, and oliguria, and there is deranged RFT and LFT, decreased platelet counts, and definitely the fetal growth parameters. Hello?
Yeah.
Hello? Yes. I'm audible?
Yes. So there are certain severity characteristics. So right from the clinical, symptoms and signs, what you have described, and there are certain laboratory investigations that you have to look for, like, as you have already talked about the liver enzymes, the renal function test, and of course the thrombocytopenia and all other, even the FGR. FGR is not considered as a parameter of severity, but yes, definitely it is indicative of the long-standing disease. So now 140/90 is not mild, but if you have all these features along with 140/90 blood pressure, it can be severe. So now previously we used to classify it as mild, moderate and severe, but now the classification is severe and non-severe. Okay, so this obstetrician, was from the previous generation and thinking that 140/90, as you can see here, previously they had a concept that once you deliver the baby, the hypertension will disappear. So nowadays, this is not true. You must have seen even the postpartum hypertensive disorders or even postpartum, even eclampsia. So that's a very reason delivery is not a good idea when it is, when the baby is not salvageable, right? So you have to take this pregnancy ahead. So would you like to start antihypertensive for this patient that we discuss first? Dr. Anushri, can we have it from you?
Yes. Good afternoon, ma'am. Thank you, Archana, ma'am, for asking me out and being a part of this panel discussion. I feel honored and grateful to be here. For the question that is being asked, that should antihypertensives be started? So initially, the criteria for starting antihypertensives was different. The BP was different, but now when it is 140/90, yes, we should start antihypertensive. The answer to the first question is yes. And the second is, which antihypertensive should be started? So the most acceptable first line and effective medication is labetalol, which can be started as low as 100 milligram twice a day. And it can vary according.
Join therapy.
Madam,
And
but my priority is going on. So I am I've joined, but I'll answer my questions. Don't worry.
Welcome, Dr. Aparna.
Hi, Dr. Aparna.
Hello, ma'am. I'm sorry I
Hi.
joined late because there is some
Koi baat
inspection.
nahi, koi baat
over
nahi.
here.
At least you joined. We saw you.
Yeah.
Our BP will be normal.
Yeah, so Dr. Anushri, you have very rightly discussed. Yes, you have to start the antihypertensive. Previously, we have this nice guidelines saying if you have the blood pressure of 150 systolic
exactly.
and diastolic 100, then you should
Then we have to start. Now it is 140/90.
Perfect. So now the concept had changed. World Justice Organization, even FOGSI and ICOG, they recommend the antihypertensive to be started at 140/90 millimeter of mercury. Okay. So Aparna, we come to you. What investigations do you want to prescribe or advise for this patient to decide what is the severity of the disease?
Actually, ma'am, I didn't hear the case. So
Okay, I think I will just say for you that this is a case of hypertension. She was perfectly all right till 32 weeks, and suddenly now her blood pressure is recorded as 140/90. So with repeat recording, we have confirmed that yes, she has got hypertension. So how do you proceed for investigation and management? So you will only speak
right
about
now,
what investigation
what I'm following in practice is right now we start with labetalol.
We'll talk about
Usually,
investigations only. What
Acha,
investigations you should
investigations, ma'am, if they have not been done previously, then hematocrit, CBC, urine routine, especially for albumin. Then, if a patient is affording urea creatinine clearance ratio, also I do. Then, uric acid, LDH, liver function test, baseline. This is for a baseline profile, so that if any complications occur later, then we have a baseline value for judging how the disease is progressing or what is the right time to deliver if it is deteriorating.
Yes.
Kidney
And
function.
also to classify it as not severe or non-severe. Okay.
Yeah.
Even with 140/90, if you have the severity characteristics in this investigation, any impairment in the liver or renal functions, we can label it as severe hypertension. Okay. So this is all about the investigations. When to start the antihypertensives, Dr. Dr. Pardeshi has already answered this question. Now, this obstetrician, she was from the previous generation. So she thought it is, 140/90, it's a mild hypertension. So she just advised her that if at all you get some alarming symptoms, and then you can report to the hospital. And she just sent her home, starting some mild antihypertensives orally. So I think anybody can take up this question. I think Namrata, you can take up this question. Whether whether she should have sent her home without investigating, whether this is a right advice that she has given. Dr. Namrata?
Sorry, ma'am. Sorry, sorry. Ma'am, as we have already decided now that the criteria of starting an antihypertensive is 140/90. So apart from not only what she should have been put on an antihypertensive, but all investigations regarding the severity should have been done. Number one. Number two, she should have been warned about the warning signs. In case, because we don't know how her PIH is going to progress. So, and all kinds of warning signs she should be warned about. She has to report as soon as she.
So without investigating, she should not have sent home. That is the basic, mistake which is done by the obstetrician here. And what are the options for antihypertensives available for this?
Ma'am, we would like to start labetalol as the first drug because it has a few advantages over the other known antihypertensives. It acts by decreasing the peripheral vascular resistance, so it has no effect on cardiac output. And as a result of this, it does not affect the central blood flow, number one. Number two, it has no effect on heart rate, which does not increase, better tolerated than most, at least better tolerated than methyl dopa. And somewhere I read that it may have a ripening effect on the cervix. I don't know. You might be able to tell us more about this, ma'am. Somewhere I read how it works. I really don't know.
Okay.
But, so I would prefer to put her on labetalol.
So you are for labetalol. You have justified your stand for using labetalol. Is there any option apart from labetalol?
Methyl dopa, ma'am.
Yes, and
nifedipine.
Nifedipine as a retard tablet. Okay, as a retard tablet for such mild hypertension. The recording is less, so you have to talk about the mild hypertensive, which is severe. Now, how do you decide? Dr. Sambul, I would ask you, how do you decide which antihypertensive? That is the first question for you. Which
Actually, according to the NICE guidelines, the first line of treatment is labetalol. If not, then we can go for nifedipine. But we can prescribe.
Between the two, how do you decide? Suppose your patient has got asthma, maybe she's got some conduction defects. So which antihypertensives which you will prefer?
Okay,
asthma
for that reason,
and conduction defects of cardiac failure.
I will go for nifedipine then.
Yes, perfect. Because asthma, conduction defects, CCR, these are the contraindications for labetalol, correct? And tachycardia or pedal edema, peripheral edema, severe headaches, this is a contraindication for nifedipine. Okay, so between both these drugs are equally effective, and both these formulations are also good to use for continuation of pregnancy. But they have their own limitations. So this is how you have to choose. Now, why not alpha methyl dopa, Dr. Sambul?
Alpha methyl dopa is having some effect. Like if both those drugs cannot be given, we can give methyl dopa, but with the caution, because it is causing more renal impairments and postpartum depression. And sometimes if it is given in the first trimester, it can lead to congenital anomalies and preterm labor.
Our patient is now 32 weeks. So we have thinking of starting the antihypertensive. So
alpha methyl dopa takes time to get stabilized.
Perfect.
Those who compared to the labetalol.
Yes.
Labetalol and nifedipine quick in reducing the blood pressure.
Yes. So
and it is not available.
Alpha methyl dopa is not available, Dr. Archana. That is the first.
Yeah, it is not available.
It was available. It has its own side effects. First and foremost, it takes almost 24 hours for its onset of action. Sometimes you add the drugs. 1 TDS, 2 TDS, 2 QID. It doesn't have any effect, and after 24 hours, you have sudden hypertension. Even when the patient has postural hypertension. Also, the patient has postpartum depression. Maybe the patient remains sedated for a long time. She doesn't even breastfeed the baby. And of course, postpartum depression and certain types of hematological problems also, like thrombocytopenia, hemolysis, the false positive Coombs test, so many other problems also. If you use it antenatally, even the non-reassuring NST, as a false effect it gives.
Yes.
So that's a very reason alpha methyl dopa should not be preferred. That is what the conclusion here from the discussion. Now, Dr. Anushri, we want to know from you, what is your policy about the bed rest, salt restriction? How do you advise the patient?
Ma'am, to be very honest, in terms of advising patients on bed rest and salt restriction is not something that I advocate all the time. But
Mm-hmm.
in case a patient comes to me with a BP of 140/90 and I have started her on antihypertensive, then
Mhm.
as a placebo, I do tell them that, you can restrict salt in your diet.
Yeah, but it is absolutely no. I mean, the restriction has to be only not top salt. The table salt should
Table
be
salt
avoided.
as well.
In fact, she
Yes.
should be consuming the adequate amount of sodium, because some of these women, they land up into hyponatremia. Okay.
Yes, ma'am.
So friends, challenges are what makes life interesting, and overcoming them is what makes it meaningful. That is how it has been expressed by Joshua Marin. So our patient, when she was, sent home without any alarming, without hospitalizing, when actually without investigating, I would say, this patient, they just thought it is mild hypertension, started with labetalol, sent home. But when you investigate, you know that it is a case of severe hypertension which needs to be hospitalized. So this lady, 5 days later, she was brought to the hospital by the relatives with severe headache, nausea, upper abdominal pain. When you examine, the blood pressure was 170/110. The reflexes are braced. There is epigastric tenderness. Very classical case of severe hypertension. And now, Dr. Aparna, how would you manage this case from this point?
I would see this is a case of severe. She needs to be admitted. This is an emergency because she may land up in impending eclampsia or her BP.
She is in impending
She is
eclampsia.
in
We want to
impending
prevent
eclampsia.
it. Yes.
Yes. So every hospital must have a eclampsia management kit with all drugs available, so that in case patient throws off convulsion, you don't have to run here and there, and you have all the drugs
Do we
in
want
that
to wait
tray.
for throwing her convulsion, or we want to give prophylactic?
No. This eclampsia kit I just mentioned, but because this patient is here, so we have to make all the arrangements for getting her BP down. So we start an IV line. We see to it that her airway is like she's okay, and then we start with if she's not already taking the drugs which we had advised on OPD management, then we can start with IV labetalol to lower the blood pressure, and we should avoid sublingual depine or nifedipine because it brings out sudden hypotension which may damage further. So everybody should remember that depine is not to be
Labetalol is
given.
a drug of choice here
Yeah.
for you. Those who are not well versed or who do not have the facility for micro infusion pump or the ICUs or HDUs may go ahead with oral capsule nifedipine 10 milligram stat. And if it is not coming down, you can repeat it after 30 minutes. But now when you want to prevent this convulsion, you want to give her prophylactic magnesium sulfate. Whether you
Yes.
should or no.
No,
How do you
we
decide?
should
So
give.
for that, I come to
We should give before shifting the patient to any facility. We are supposed to give magnesium there and then, and that too in full dose.
perfect. So that is what the message is. We must give prophylactic magnesium sulfate, and the message here is whether it is prophylactic or therapeutic, it has to be a complete loading dose. Okay. So it has to be a complete loading dose. Now the question here is 170/110. This patient has got severe hypertension, there's no doubt, but you have to differentiate between hypertensive urgency and emergency. So why that is so? What is the difference between the urgency and emergency?
Urgency is when there is a sudden shoot in BP, but there is no end organ damage associated with, and it needs to be controlled within a day, within 24 hours. While hypertensive emergency is severe hypertension, but is associated with end organ damage, and it needs to be controlled as soon as possible.
So you need to send her blood investigations immediately to see that whether she has end organ damage. Otherwise, if you fail to recognize all this, then the patient may land up into all these complications, including eclampsia, cerebrovascular accidents, hepatic rupture, cardiac failure, pulmonary edema, and even myocardial infarction. Okay. So Namrata, we come to you now. What are the drugs available for management of the severe hypertension? Dr. Aparna has already talked about injectable labetalol. I want you to elaborate the use and the protocol as well, and which are the other options available.
Okay, ma'am, labetalol, as I read it, and as I give it also, is 20 milligram. If we don't have an infusion pump, I'll talk about the start doses. 20 milligram IV over 2 minutes. Wait for 10 minutes. If the PP does not come down, increase the dose to 40 milligram IV over 2 minutes. Wait for another 10 minutes. And then add it and then use 80 milligram IV. But in the next 10 minutes, if the PP does not come down, add hydrolysine. With
so you need to change the drug. You need to add another drugs. Okay. So what are those other drugs?
The hydrolysine, ma'am, we can add hydrolysine about 10 milligram IV along with 40 milligram labetalol can be added. And
hydrolysine to start with, you must use only 5 milligram, Dr. Namrata.
To start with, it has to be just 5 milligram, ma'am. Wait for 20 minutes, then increase it to 10 milligram, wait for another 20 minutes. We can give nifedipine also, ma'am, but nifedipine, not sublingual, of course, never sublingual in these cases. 10 milligram orally, wait for 20 minutes, give 20 milligram orally.
Because for oral nifedipine also, the onset of action is within first 5 to 10 minutes. The peak action is within 30 minutes. And the duration of action is 6 hours. So nifedipine orally also gives you a very good desired effect for the fall in blood pressure. Okay, and it also, it doesn't lead to sudden drop in blood pressure as it happens or the patient collapses with a sublingual nifedipine. Okay, so our policy should be such that, there should not be sudden decrease in the blood pressure. It should be only 25, almost 20 to 25% reduction. So if it is 170, 110, it will be 160, 100 initially. That slowly you have to, bring down the blood pressure and maybe up to 150, 100. Then you maintain on this because the fetal circulation is adapted to this. And, if you try to lower down the blood pressure still further, maybe there can be the fetal hypoperfusion and fetal jeopardy as well. So nifedipine and labetalol you have discussed. Hydrolysine, you were talking about, Dr. Dr. Anushree.
From hydrolysine, we were starting at 5 milligram IV dose, and then 5 to 10 milligram we give every 20 to 40 minutes. Once the BP is controlled, then every 3 hours we can give it in infusion form.
Yeah, but how much maximum hydrolysine?
So, ma'am, if it doesn't go up till 30 milligram, then we switch on the drug.
Yes, so 30 milligram is the maximum dosage for hydrolysine.
Hydrolysine.
Of course, you have NTG infusion, nitroglycerin, and sodium nitroprusside. So these are the drugs. There are certain other, this is just a message for all the attendees that, as I have talked about, nifedipine is a very good, very effective antihypertensive for effective control, but it is never to be given sublingually, because we have seen patient collapsing and even
sudden hypotension.
Yes. So anything about nicardipine you want to say?
So the starting dose of nicardipine is almost like 1.5 milligram per hour. It was difficult for me to remind it. मैंने बहुत याद किया to tell the dose क्योंकि मैंने use तो नहीं किया है, लेकिन I just memorized it. So then it is increased up to 6 milligram per hour for the effect to come.
Yeah. But then just the category of drug, it is the same as, calcium channel blocker like nifedipine.
Yes, exactly. It's same like dipine, but it is 100 times more water soluble than nifedipine.
Yes. And that is why injectable formulation
IV may be
available. And intensivists are more in favor, or the cardiologists are more in favor of using this drug, not the obstetrician. Yes, okay. Exactly. Any comment on esmolol? Esmolol is also a very useful therapeutic agent in obstetrics. Even anesthetists prefer to use it, but though I have personally not used it in any case. It is an ultra short acting cardioselective beta adrenergic blocking agent, and this is also available for IV use as a bolus. So when you have severe hypertension, you want the blood pressure to come down urgently. So you are facing this hypertensive emergency. So now you have use the antihypertensives and try to control the blood pressure. What other, suppose now you have stabilized this patient from the very severe hypertension, may it be emergency or urgency. Now you want to pull on this pregnancy till salvageability. So when everything is fine, you can go ahead. But what are the clinical findings, that make you or warrant you for termination of pregnancy before 34 weeks? Dr. Sambul.
Actually, if it is urgency, then we have to terminate. And there is a complication like eclampsia, abruptio, HELLP syndrome, renal failure, and fetal distress. Then we have to terminate the pregnancy.
Yes.
Coagulopathy is also there. If it is doubling, deranged like HELLP syndrome is there.
Yes. So
And in fetal
whether the
parameters like absent and
complications like
diastolic fluid.
eclampsia or abruptio.
Yes.
Yes. So you have certain fetal indications and certain maternal indications. So if the mother lands up into complications of eclampsia or abruptio placentae or HELLP or acute renal failure, then you have to terminate the pregnancy in maternal interest. Or maybe even the fetus, you are trying to pull it on, but suddenly you find that the Doppler is showing such changes that you may land up into intrauterine fetal death. And that is a time where you have to terminate the pregnancy, or if at all you have the intrauterine fetal death, that is a time you have to think, you have to actually go for induction of labor. So what is the role of prophylactic MAC-self and what is the regime you prefer, Dr. Anushri?
So, ma'am, prophylactic magnesium sulfate should be given for neuroprotection. The regime that we follow is Pritchard regime. It is a dose wherein the loading dose is 14 grams.
I try to clarify from you that prophylactic MAC-self for this patient, are we giving this as a prophylaxis to eclampsia or as neuroprotective to fetus?
As prophylactic to eclampsia, because the patient has all these impending features.
My dear, you're right. You say that for both. You are giving it. You are giving it as a priority to prevent convulsions, but at the same time, it is acting as a neuroprotective for the patient.
Yes,
so
definitely.
it is helpful for both, but you are giving it for priority on priority to maternity.
Eclampsia.
Yeah. Okay.
Yes, ma'am.
So which regime, how?
So we follow the Pritchard regime, in which we give 14 gram magnesium sulfate as loading dose and 5 gram each on the buttocks. Now, how do we give the loading dose? So the ampule that comes is a 50% weight by volume ampule, wherein it is 2 ml and it has 1 gram in it.
Correct.
So we take 4 ampules, which is 4 gram, equals to 8 ml. And to make it 20% weight by volume, we dilute it with 12 ml so that it becomes 20% weight by volume. And then we give it slow IV over 20 minutes. Because we want the rate of infusion to be 1 gram per minute, like that. And then we give them 5 gram intramuscularly on each buttocks, which doesn't have to be diluted.
Need not be diluted. Intramuscular need not be diluted. Okay,
and then
so
the maintenance dose
initially.
Yes, and then the maintenance dose is 5 gram deep intramuscular in alternate buttocks 4 hourly.
Yeah. What do you monitor meanwhile?
So we meanwhile monitor the respiratory rate, which should be more than 16 per minute. The patellar reflexes should be there. The knee jerk should be checked. Then the output, urine output should be measured, which should be more than 100 ml in last 4 hours that we have seen.
Yeah, at least 20. What you are saying is right. 25 ml per hour. Correct.
30 ml per hour, exactly.
Yeah. So it should be ideally 30 per hour, but then even if it is 25 per hour, as you are saying, 100 ml in 4 hours, that is also correct. But that is a limit where you have to stop yourself.
Stop magnesium sulfate.
Yeah. So if you find that the patellar reflex is absent, then what do you do with the? If you have the dose due now, then what do you do?
We do not give it further.
Yeah, we do not give. We skip only that dose of the MAC.
That particular dose.
After
yes,
4 hours, once again you see that if the reflexes are still present, then you will.
Then we continue it.
Yeah. So, but then if the reflexes are still absent, or the urine output is less, or there is a problem with the respiratory rate, you definitely abandon the magnesium sulfate regime and you start giving the, maybe the patient may need, you have to evaluate whether the patient needs the antidote. Okay. So,
Calcium gluconate.
yeah,
Yes,
yes. So, Aparna, now we ask you, how often do you repeat this investigation? Your patient is a case of severe hypertension. You have evaluated her, you have labeled her that whether she has some impediment. Somebody has talked about that, yes, we should have the basic, investigation reports in our hand, and we should be able to know how she is progressing. So how often do you repeat this investigation for this case of severe hypertension? And at
Urine
what station would you deliver her?
urine albumin we can do daily, and after 48 hours we monitor lab parameters, and if she is progressing fast, not being controlled, any deterioration in clinical symptoms, then we may do these investigations earlier also.
Yeah.
We deliver at
Suppose,
gestational.
yeah.
Yeah.
Suppose you do the investigation and you find that there are some derangements in the liver function and renal function. Then how often do you repeat it?
6 hourly also, ma'am, to see if she is not going in DIC.
Liver function and renal function. See, there is a norm that if the investigations are normal, maybe even once a week it is okay. But for this case of severe hypertension, twice a week at least, every third day. But if you find that there is derangement, then every alternate day, at least after 24 hours, you have to repeat it. You're talking about the platelet count. If the platelet count is low, then definitely the platelet count and coagulation factors, if they are deranged, then you have to repeat it every 4 to 6 hourly. Naturally, now we have controlled the severe hypertension. We have stabilized our patient. We have taken her on again, tablet nifedipine and tablet labetalol. The patient is stable. Everything, you are going ahead. You are reaching almost 34 weeks. When do you deliver this patient?
For 34 weeks, we give prophylactic dose of corticosteroids for lung maturity and neuroprophylaxis, and then we deliver. Like patient stable, we deliver after 36 to 48 hours to let steroids act.
Yes, yes. So how do you talk to the patient and relatives about the prognosis of the neonate?
Because
see, once again, I a little difference of opinion here. Suppose you have stabilized the patient and now everything is fine. Even if you find the Doppler is also fine, you give her steroids. But do you want to wait for some more time, take some time, or you want to deliver her?
If Doppler is fine, I usually wait and repeat Doppler after 48 hours. We keep on doing Doppler till there is no MCA impairment and drastic decrease in umbilical artery blood flow. We can continue the pregnancy under our monitor, but patient has to be kept in the hospital. She cannot be discharged even if the BP returns to normal.
Yeah, that is a basic, the most important message here. She is a case of severe hypertension. Anytime she can, land up into end organ damage, and if at all she has not had previously. So this patient is not to be discharged. And the moment that she is approaching 34 weeks, you have given her neuroprotective maxas, you have given her steroids. The best way is to deliver her. Okay, not at the cost of mother's life. You should not prolong the pregnancy. If everything is fine, your Doppler parameters are good, then maybe you may take some time, 3 days or 3 days more. So repeatedly, you have to go for the Dopplers as well. But you should not stretch this pregnancy, definitely not beyond 37 weeks, but at the most 35 to 36 weeks. That is what the message is. Now, what is your plan of, action, Dr. Namrata? Your patient is now, she has reached that period of salvageability, or because of maybe some impairment in your investigation, you need to deliver this patient. So what anesthesia, suppose she's not, not favorable for vaginal delivery. If you examine her Bishop score is not favorable, the head is floating, and there is not adequate fluid also. So you feel that this patient is for cesarean section. What type of anesthesia you would prefer, whether it is regional or general anesthesia?
Ma'am, I would like to deliver her in epidural anesthesia actually.
Okay, perfect. So regional, but preferably epidural, right? Okay.
will be applicable because spinal, we tend to have a sudden hypotension in these patients. And general anesthesia, ma'am, if the patient has deranged parameters of liver and renal parameters are deranged, maybe even impending DIC or coagulopathies, then the risks of general anesthesia are more. So I would not like to put her on a general anesthesia.
One more condition where you want to prefer general anesthesia when the patient is in status eclampticus.
Yeah, that is okay. But in any case, we have to intubate her. Yeah.
Yeah. So you have managed this patient very well. You are thinking of, pulling her to 34 weeks, close to 34 weeks, everything is fine. But suddenly this patient complains of severe, you're trying to pull her, beyond 34 weeks, which should not be done. That is why this message here, that one fine day, suddenly she started getting severe pain in abdomen, headache, her blood pressure is once again 170, 110 and reflexes subrests. When you examine her per abdomen, the uterus is tense and tender, fetal parts not well filled, and her fetal heart going down to 110, 120, and there's little bleeding from the vagina. Os is hardly 2 finger, but the station is high up. What is the complication which has happened here? What investigations to confirm? This is very and this is a spot diagnosis, but yes, let us.
She has developed abruptio placentae, and we need an ultrasonography to see the clot, how much is the clot, and we need to prepare her for emergency LSCS for delivering the baby at right point and appropriately.
Yes. But then at this point of time, do we need to go for some investigations again in addition to ultrasound? That is the coagulation profile.
That lab parameters we will send. Then, ma'am, this is a very emergency situation, so we have to act on all the fronts. Like one is doing lab parameters, one is doing ultrasound, one is preparing for a cesarean section, because abruptio baby they deteriorate and you get IUD very, very fast.
Yes. So it has to be a teamwork, and such patient has to be, managed at a multidisciplinary setup. Though we too manage it individual setups, but there has to be a team which is, taking care of the mother, the baby, and the blood and blood products. Everything you have to prepare the OT, anesthetist, the neonatologist, and the blood bank. Everything should be well prepared. So the investigation reports, meanwhile, you are trying to, get her into OT. You find the coagulation profile. Platelet count is only 50,000. The bleeding time and clotting time, they're quite good. Fibrinogen is only 150, and fibrinogen degradation products, they are present. That means she is in frank DIC. Okay. Yeah. So you have already ordered for blood and blood products, and maybe you have won the blood bank that she may require a massive transfusion protocol may be initiated. So you have, informed them. So how do you score the DIC? Dr. Anushri, you can take up this. What parameters you take into consideration and how do you score it? Anushri, do we have Anushri or Namrata? Anybody can take up.
Should I?
Yes.
Okay, we score the results with on the basis of platelet counts, elevated fibrin degradation products, the prothrombin time, and serum fibrinogen. And each degree of severity is accorded a score. Like, for example, if the platelets are more than 1 lakh, we give it a score of 0. And if they are less than 50,000, we give it a score of 2. And similarly, the fibrinogen degradation products, if there is a strong increase, it's a score 3. If they are normal, it's a score 0. And similarly, prothrombin time and fibrinogen also, serum fibrinogen more than 100 milligram is okay, but if they're less than 100 milligram, it's a score 1. And that's how the DSC scores are then done.
So you score it as 5. So what is over DIC and what is non-over DIC?
Overt would be a score of more than or equal to 5, ma'am, and in which the repeat tests have to be done after every 12 hours, 6 to 12 hours, depending upon the severity and the improvement. And non-overt would be a less than 5 score of DIC.
Yes. So now that you have arranged for blood and blood products, because the whole blood alone will not do. In fact, it is not advisable. So, Dr. Anushri, I mean, with this fibrinogen levels of 100 mg/%, what blood product or blood component you want to give it to this patient, and how would you initiate the blood transfusion protocol? You want to take up this, or Dr. Sambul can?
Fresh frozen plasma should also be arranged in such a patient when
Yes.
the fibrinogen levels are
Yeah.
take it.
So 15 ml per kg, whether first you have to do the prothrombin time and APTT also. If it is prolonged, then you need FFP as well. So 15 ml per kg, that is what FFP required. Otherwise, what you do is, how do you start the blood transfusion? That is what I'm asking you. The packed RBC and FFP in the ratio of 1:1. Dr. Sambul, you can take up this discussion. Anybody, I would say.
1:2:1, ma'am. Is it?
Initially, you have to give it. In fact, initially it can be 1:2 or rather 2:1. But then when the FFP and cryoprecipitate is also available, you have to make it as 1:1. Okay. So alternately, you give RBC and FFP. But for
But her platelets are low, so she needs platelet transfusions also.
Yeah. So actually, when you are giving this cryoprecipitate, definitely you are having the fibrinogen also. And when you are giving FFP, you're getting all the coagulation factors also. Platelet usually 50,000. We do not require any, platelet transfusions.
Then below 50, we can't operate, no?
Below 50. Below 50. Yes.
50.
So it is always better to keep the platelet packs, at least 4 platelet packs ready. So you have to order this way. Okay. So now this patient I have been talking about, that even in spite of receiving the antihypertensives, controlling her blood pressure, she received magnesium sulfate also. In spite of all this, her headache, persisted throughout. So there was a suspicion that, there may be some problem intracranially. So her MRI was done. And this is what the picture, the white matter consistent, it is showing the vasogenic edema. So what is this diagnosis?
Press syndrome.
Yeah.
Press syndrome.
Posterior. Yeah.
Posterior reversible encephalopathy syndrome.
Encephalopathy syndrome. So any comment on this, Dr. Sambul? Whether we should really worry about this? Can you prevent this? Is there any definitive treatment, or what is the best part of it?
It gets limited.
Whenever the patient is complaining of headache or some seizure, or we think that there is a intracranial involvement, we should always confirm it with CT and MRI. And as we know that this MRI is showing edema, so immediate delivery and immediate control of blood pressure. And we'll see for other associated conditions like autoimmune disease. And maybe the patient is taking high dose of corticosteroids and anti-epileptics to be given. And if edema is more, then steroid to be given.
But we are giving magnesium sulfate to our patient, not to control the convulsions also.
Yeah.
So I don't think there is any additional need for anti-epileptics. But the best part of it is, the question here purposefully why I have placed it. Can it be prevented? No, we cannot prevent it. Only, right from the beginning, good control of blood pressure. That is the only thing you can do. And the best part of it is totally reversible within first week of, after the delivery. So that is what the best part of it. We should be, fortunate enough to explain to our patient and her relatives that maybe, she will recover within next 1 week. That is what we can just tell them. Hello, anybody wants to add something? There's no neurological manifestation after 7 days. So that is how,
I had a patient who had sudden loss of vision, third post-operative day. She was I operated her upon her for severe PH.
Yes.
Though her BP was maintained, she suddenly one day she says, I can't see. I thought she had some kind of retinal detachment post, her PH. But
retinal detachment, yeah. Oh.
So then we got an MRI done. It was a press syndrome, and she, of
Yeah.
course, this
So
very
loss of vision, severe persistent headache in spite of normal controlled blood pressure. That is what very classical of praise. And but yes, you have to be really cautious in explaining the patient and the relatives. You have to take precautions. All of a sudden you can't. That's a very reason your role of counseling and informed written consent comes, because once the patient comes to you with severe hypertension, you need to explain them, rather predict what complications can happen, and you need to make them right, that they have understood what you are saying, that you are trying your best to get the best outcome from this pregnancy as far as the maternal aspect is concerned, as well as the fetal aspect is concerned. But the situation is such that the patient may land up into all these complications. That is what is to be explained and written by the patient and relatives. I think that is what the key to success for, from protecting yourself from the medical legal complications or litigations, as we call it as. So friends, crisis is integral to human life. Those who timely and appropriately contract it will survive and succeed. That is what says Gita. And these are just the take-home messages. From this case, what I want to tell you is prediction has got a very, very important role. So right from maternal characteristics, the biophysical and biochemical test, you must predict. Nowadays, there is what is called as inverted pyramid of antenatal care. So it's not that, all of a sudden, as a surprise, the hypertensive disorder comes to your visit. No, you can definitely predict it at 11 to 13 weeks by the uterine artery pulsatility index, the biophysical and the biochemical markers. So the moment you diagnose the hypertension, you must use the appropriate antihypertensives in appropriate dosage, and you must follow this patient with good clinical as well as whatever laboratory investigations, may it be ultrasonography or maybe the biochemical markers, and you must act appropriately and timely to get the best of the outcome. So with this, I thank all of you, and I thank all of you for all your blessings and wonderful inputs from all the panelists. I'm very happy to see that the panelists are very well prepared and they have contributed to the discussion to the best. Thank you so much, Dr. Archana, for your invitation, giving me this opportunity to moderate the panel. And thank you so much, everyone, for being here. Thank you.
Thank you, Sneha, for putting all the efforts. And I was listening throughout, and it was wonderful inputs by everybody. Sumbul, I really like your way, and Aparna, Namrata, and heroine Anushri, all.
Thank you, ma'am. Thank you.
Very well done, very well done. It was like this. It was almost mesmerizing. Like I was listening this and this, whatever. Even sometimes I was talking on phone, but my eyes and ear were at this laptop only. Very good, very well made, and very well executed. Wonderful.
Thank you, madam.
Thank you so much. Thank you, dear.
Thank you, Sneha ma'am. Thank you, Archana ma'am. Thank you, everybody, for joining. And we hope to have more such programs in the future, ma'am.
Thank you so much.
Thank you so much, faculty and the attendees. Just once again, just letting you know of our quality product that we have recently launched, Lycored M tablets for male infertility, and our natural micronized progesterone range, that is DivaGest SR 200 tablet, DivaGest SR 300 tablet, DivaGest 200 vaginal soft gels, and DivaGest 100 mg injections. And then the progestin people that Jackson Pal is known as, we have all the range of progesterone. We have natural micronized progesterone. We have dydrogesterone as DivaGest. DivaGest is our natural micronized progesterone. Divatron, our dydrogesterone. Tablets maintain our 17-hydroxyprogesterone injections, maintain tablets of allylestrol, norethistrone as Cyclorex CR10 and Cyclorec plain as Cyclorec 5 mg, then Dynogest 2 mg tablets of Endorec. Thank you all very much, and we hope to see you again.